All right, let's dive into a really high-yield topic, anesthesia for patients with obesity. In this explainer, we're basically going to walk through the patient's entire journey, all the way from the pre-op clinic to their recovery. This should be perfect for your exam revision or just a solid clinical refresher.
So here's our roadmap. We've got it broken down into four main parts. First, we'll get a handle on just how big this challenge is. Then we'll cover what happens before surgery. After that, we'll get into the nitty-gritty of the anesthetic itself. And finally, we'll talk about recovery and what to watch out for.
First up, let's set the stage. Why is this such a hot topic in anesthesia right now? Well, it really boils down to two things: the sheer scale of the problem and the very unique risks that come along with it.
To put this into perspective, just look at this number. The World Health Organization estimates that over 650 million adults around the world are living with obesity. And get this, that number has actually tripled in the last 40 years. So this isn't a niche topic, it's a massive part of our daily practice. So in the clinic, how do we start to categorize this? Well, we use the body mass index, or BMI. As you can see, the WHO defines class 3 obesity, what used to be called morbid obesity, as a BMI of 40 or higher. Now, what does that mean for us? It typically puts the patient in the ASA3 category. That's our physical status classification, and it immediately tells us we're dealing with a patient who has significant systemic disease. It's a flag right from the get-go. But, BMI is just a number. It's height and weight. It really doesn't tell us the whole story. Where a patient carries their fat is a much, much better predictor of their risk. So patients with that central or apple-shaped obesity, they have more of that dangerous visceral fat. It's metabolically active, and it's what's strongly linked to a much higher risk of things like metabolic syndrome and heart disease. Okay, so that sets the scene. Let's move into our next section: getting the patient ready for surgery. This is where we do our detective work, right? We identify and manage all those risks before they even get near an operating theater. A really meticulous preoperative assessment is absolutely vital. We are on the hunt for all the common comorbidities that go hand in hand with obesity. We're talking about serious respiratory issues like obstructive sleep apnea, the strain on the heart from hypertension, and of course, metabolic problems like type 2 diabetes and fatty liver disease. So how do we actually screen for these things systematically? Well, for something like obstructive sleep apnea, we have validated tools like the Stop Bang score. It's a simple 8-point checklist. It helps us flag those high-risk patients who might need more tests or maybe even need to start on something like CPAP therapy before their surgery. And to get a sense of the overall surgical risk, we can use another tool, the Obesity Surgery Mortality Risk Score, or OSMRS. This one uses 5 key variables to help us predict which patients might have a rockier postoperative course. For instance, a score of 4 or 5 should make us really think hard about booking a high dependency or an ICU bed for them after the operation. And here is the absolute crucial point, the take-home message for this section. Bariatric surgery is elective. That means we have a window of opportunity. The goal always is to find and tune up all these comorbidities before the day of surgery. It's all about maximizing safety and giving our patients the best possible chance of a great outcome. All right, the patient has been fully prepped and optimized. We're now in the operating theater. This phase is all about the specific techniques and very careful management that we need to pull off a smooth and safe anesthetic. Okay, a safe induction is everything, and it really comes down to 3 key steps. First, positioning. This is huge. We induce the patient in the ramped position, building them up so their ear is level with their sternal notch. This uses gravity to help us. It pulls all that abdominal weight off the diaphragm, which makes ventilation easier and gives us a much better view for laryngoscopy. Second, we pre-oxygenate really well to build up that oxygen reserve. We're aiming for an end-tidal oxygen of 90%. And third, you have to have a solid airway plan. Tracheal intubation is the gold standard here, and you should always have a video laryngoscopy right there and ready to go. Now, before we even talk about drugs, we have to understand a core concept: lean body weight, or LBW. This is a calculated weight that basically ignores all the fat mass. So why does this matter so much? Well, a lot of our key anesthetic drugs are water-soluble. They don't spread into fat tissue. So if we dose them based on the patient's total body weight, we would give them a massive overdose. And this is where it gets really practical. For our induction dose of propofol, or for a non-depolarizing muscle relaxant like rocuronium, we're going to use that lean body weight. But, and this is a big one to remember for exams, there are important exceptions. For succinylphonium, we actually use the total body weight. Why? Because the enzyme that breaks it down, plasmacholinesterase, actually increases in patients with obesity, so they need more of the drug, not less. So what kind of operations are we actually talking about here? This slide gives a great visual. They range from the gastric band, which is purely restrictive, to the sleeve gastrectomy, where a big part of the stomach is actually removed. And then you have the more complex Roux-en-Y gastric bypass, which is a combination of restriction and malabsorption. The surgery is done, the drapes are off, but our job is definitely not over. The postoperative period is a time for high vigilance. We really need to anticipate and manage a pretty unique set of potential complications. So in those first few hours and days, we're on high alert for some really serious issues. The one we all fear is an anastomotic leak. And a key sign, a real red flag, is a persistent tachycardia that you just can't explain. That should be considered a leak until you've proven it's not. We're also really vigilant for blood clots, bleeding, and those common lung complications like atelectasis.
And the challenges don't just stop after a few days. Long-term, patients can face a whole different set of problems. Especially with the malabsorptive procedures, you can see major nutritional deficiencies that mean lifelong supplements. Some patients experience dumping syndrome if they eat sugary foods, and there are later surgical risks like internal hernias, not to mention the huge psychological impact of this whole journey.
So what about the long-term outcomes? Which surgery is better? Well, the evidence here is fascinating. We've got these major randomized controlled trials, like the sleeve pass and SMBOSS trials. They directly compared the two most popular procedures, the sleeve and the bypass. And what they found was pretty interesting. At 5 years, there was no significant difference in overall weight loss between the two. That's crucial information when we're helping patients make these big decisions. So what's the big takeaway from all of this? The bottom line is that bariatric surgery, when it's done in experienced centers, is incredibly safe and effective. And this is the key part, it is not routine. It demands a detailed, individualized anesthetic plan that thinks about every single step of the patient's journey, from that first clinic visit to their long-term follow-up. The question really isn't just, can we do it anymore? It's how do we keep refining what we do to make it even safer?